We're talking about sentinel lymph node detection in women with uterine cancer, in especially what the situation is in African women. Because there's quite a lot of data coming out of Europe and North America that detecting the sentinel lymph node in uterine cancer is a viable option that can be used as part of tailored treatment. And in some cases, like in endometrial cancer, it is becoming the standard of care where sentinel lymph node dissections are done, and that's all that is done. Now, there's no data on women in Africa, and we need to investigate this because, especially in South Africa, with a very high incidence of tuberculosis, HIV, and pelvic inflammatory disease, we do not know how these diseases would influence the lymphatic system and the functioning of it. So we actually need to investigate that. So we are busy with a study. We are looking at the best way of detecting these lymph nodes to see if there's lymph node spread. Because one of the things that goes with sentinel lymph node biopsy is minimally invasive surgery, where we do cancer surgery through a laparoscope, which allows the woman to recover quicker, which I think is very important in the resource-poor setting for these patients to get back to work as soon as possible, because they are out of an income for the time that they are sick. So we are investigating this, and from our preliminary results of the first about 30 patients we have on the study, it seems that our detection rates is a bit lower than what is reported elsewhere in the world. We think that this is because of these infections of HIV, TB, and pelvic inflammatory disease. Because if we do a sub-analysis of results and we look at patients who have signs of previous infection, compare them to patients who don't have signs of previous infection, then the patients with previous infection are the ones that have lower detection rates of these lymph nodes. The methods available, the one that we use at the moment is methylene blue. So we would inject methylene blue in the cervix, and we also inject technetium into the cervix, and then do a lymphoscintogram before the time. And in cases of open surgery, you can then use a gamma probe to find these. We don't have a laparoscopic gamma probe. We are in the process of getting one. So that would be to increase detection rates. And then from next year, we will be looking at indocyanide green, which is another way of doing it, but for that you need a near-infrared camera. And we have been able to get a loan model from one of the companies, for which we are very grateful. So we will have it for next year to see if it makes a difference. What we hope it will do is to put us in a position where we can identify which patients are the best ones, or for which patients is it safe to do it. And that's what we're hoping to get out of that, because it remains a good option, and we must first see how good this option is before it becomes sort of recommended therapy. So hopefully when the study is completed in a year's time or so, we will have an idea which category of patients would actually be good candidates for it. But the way that sentinel lymph nodes work is that you can do it on every patient. So if you do it on the patient and you don't find the sentinel lymph nodes, then you will just go ahead and remove the rest of the lymph nodes anyway. But it will be important, very important, to also look at false negative rates, so that we can know which patients, in which group the false negative rate might be a problem, so that we avoid doing it in that group of patients. We are going to recruit 100 patients to the study of both cervical cancer and endometrial cancer, early stage.